Welcome to the Practicing Clinicians Exchange podcast. This podcast series was developed from a live PCE conference focused on gastrointestinal and genitourinary cancers, including gastric cancer, colorectal cancer, hepatocellular carcinoma, bladder cancer, and prostate cancer. In each episode, you will hear the latest evidence and expert recommendations for the care of patients with a specified malignancy. In this podcast series, each of these topics will be discussed in 2 podcast episodes covering didactic presentation of the available evidence, relevant case discussions to illustrate clinical implementation strategies, and the audience Q&A session. Be sure to listen to the 2 podcast episodes for each topic in sequential order, as they may include examination of continuing case studies with patients progressing through different stages of their care. To claim your credit, please visit pce.is/GIGU.
I'm Terran Sims. I'm a nurse practitioner at the University of Virginia, Department of Urology in Charlottesville, Virginia. Our topic is advanced urothelial cancer, applying new therapeutic options. Our first speaker will be Dr. Balar, an associate professor of medicine at the Division of Hematology Oncology at NYU Langone Health, New York.
The basis for erdafitinib approval was the BLC 2001 study. This was a phase 2 open label study. Also was part of kind of a little bit of a dose finding study. There were schedules of, sequencing, weeks on, weeks off, lower doses. Eventually 8 milligrams once daily was the ultimately determined dose. 99 patients who were treated. All patients were selected centrally using a PCR-based assay for certain FGFR3 gene mutations. Now, the most common ones I will tell you are S249C and Y373C. Less commonly are the other ones listed here. And then certain gene fusions. We do see TAC3, FGFR3 mutation gene fusions from time to time. And then FGFR2, once in a blue moon, you might find 1 or 2 of those. But really, it's the FGFR3 alterations that you're going to see that would make a patient eligible for it. This swim lane plot tells you exactly how these patients do with time. 40% response rate, durability, not quite what we would expect. It's not what you would see with immunotherapy, but it's what you would expect with a potentially cytostatic agent like a orally administered TKI. Responses tend to occur early. Some last for several months. And then you have several that last for sometimes for many, many months, 10, 15, perhaps up to 20 months. And these are the tumors that are just exquisitely oncogenically addicted to FGFR signaling and don't develop resistance mutations, let's say, such as gatekeeper mutations, et cetera. For reasons that we don't fully understand, right? So there's so much work that needs to be done in the field of molecularly targeted agents in bladder cancer. So what happened in lung cancer is likely to happen in bladder cancer over the next 5 to 10 years with newer agents and understanding resistance mechanisms. Now, what about adverse events to note with erdafitinib? This is the stuff to look out for. Ocular disorders. This condition called central serous retinopathy, which affects the retina of the eye, also called retinal pigmented epithelial detachment, RPED. Same thing. This is unique to FGFR3 inhibitors, actually pan-FGFR inhibitors. So it's across the class. They occur early within the first 1 or 2 months of treatment. Patients should all get OCT exams at baseline and then monthly for the first 4 to 5 months of treatment. Usually a dose hold and dose reduction. This is usually mitigates the toxicity. It is a almost entirely reversible toxicity. Other things to watch out for are hyperphosphatemia, usually treatable with, and this is actually a pharmacodynamic effect that occurs through phosphate handling in the kidney, but can be also managed with diet alterations and also phosphate binders that you can take by mouth. Majority of these drugs are going to have some form of embryophil toxicity, but that's less clinically relevant than the 2 things that I just pointed out. Paronychia and onycholysis. This is a big issue, impacts quality of life for our patients, rash, diarrhea. So all these things are significant in terms of how patients experience drug, even if they're deriving clinical benefit in terms of efficacy. Let's just touch again on the ocular toxicities. This was a closer look at the frequency of CSR that was observed on the BLC 2001 study. Just to highlight what I mentioned about kind of the timing and the monitoring of CSR that needs to be done clinically. So essentially, the majority of the events, if they're going to occur, month 3 or month 4, after that, you don't see any more of them. And so that's why monthly for the first 3 to 4 months is really important. After that, you probably don't need to do it, but maybe once every 3 months just for monitoring purposes. So what about other management guidelines? So hyperphosphatemia, you got to reduce, phosphate intake. This is where, having access to nutritionists who can give a really good kind of a diet to patients to allow them to reduce their phosphate intake. But even for patients who, develop a hyperphosphatemia of greater than 7 milligrams per deciliter or greater, you can honestly just add a phosphate binder. So it's less intrusive in terms of their quality of life and having to make major adjustments to their phosphate intake. Because the flip side of this is that if you reduce their phosphate intake, it often means that they're eating other foods that they probably shouldn't be eating, which can also, exacerbate other medical conditions, like whether it's their hypertension, whether it's their diabetes and other things, high calorie foods. So it's a real tough balancing act in terms of finding the right foods that they can eat, because obviously these patients have other medical conditions as well. Other adverse events, some general guidelines that we say, hey, listen, if grade 3 or worse, hold until you get grade 1. Essentially, because of the nature of this drug, it has a set half-life. You wait till the drug clears, and usually a dose reduction is necessary for some of our patients. But for patients who don't develop hyperphosphatemia, you can actually raise the dose of erdafitinib from 8 milligrams once a day to 9 milligrams once a day. All right. So neuropathy, it's kind of far and away the biggest kind of concern of the toxicities that you really need to watch out for patients who are receiving enfortumab vedotin, the microtubule disrupting agent, the monomethyl auristatin E, the MMAE payload. It's going to cause neuropathy with continuous dose exposure. And since the majority of the patients will have some sort of therapeutic benefit and they're going to be on treatment for a while, you're going to see a lot of neuropathy. So it's really important to understand that that's something to look out for. Again, drug-drug interactions are always a major consideration. And the ones that are listed here are really important to consider for enfortumab vedotin and then sacituzumab govitecan, as well as erdafitinib. And so, having your pharmacist and certainly our prior authorization specialists include pharmacists who review the patient's ongoing medication list to make sure that there's no significant drug-drug interactions before the patients are started. Always identify and avoid concomitant therapies that may interact with cancer therapies. There's always going to be something that you have to look out for when you're looking at drug-drug interactions. All right. So let me hand it back to Terran, who will continue the case.
Yeah, thank you. So important to think about those drug interactions. So you initiate treatment with enfortumab vedotin, and after 2 treatment cycles, Sean reports that he's had a bothersome rash for about 2 weeks. It seems to be worsening. Has scaly patches and itching.
Yeah, so this scaly rash and the itching with DV is very common. So rash is also quite common and tends to occur. If it's going to be bad, it tends to occur early. So here are some of the main things to watch out for enfortumab vedotin. Hyperglycemia and skin toxicity are early events. So median time to onset, when we looked at, kind of the key studies, whether it was EV301 or the 2 cohorts of EV201, median time to onset, basically first 1 to 2 months. That's when you're going to see it. Whereas neuropathy is more like 4 to 5 months. And you have to manage it. And the skin toxicity in particular is managed with topical steroids and creams, emollients, the itch that patients often can get. Dual antihistamine blockade is very helpful. Topical steroids are quite helpful, but for some patients, it can be quite severe and they may need oral corticosteroids. Phototherapy is also quite helpful. And so, I always keep a dermatologist within arm's reach for some of these higher grade events you have to look out for. But the key things, hyperglycemia, neuropathy, and skin toxicities. Ocular disorders, interestingly, they're listed here as an adverse event to look out for with EV. But that's because Nectin-4 expression is seen on the cornea of the eye. So this is very different than erdafitinib, which actually affects the retina. That's the posterior compartment. Cornea is the anterior compartment, like the front of the eye. So patients will get kind of irritative eye symptoms like, conjunctival injection and tearing and kind of eye irritation, which is often managed with artificial tears and topical, eye drops, steroid eye drops. Very effectively. Again, ophthalmologists should help you manage it, but it's a very different type of ocular toxicity as compared to erdafitinib, which affects the retina and actually can cause blurry vision. Infusion site extravasation, always a concern with any infusional product. And of course, embryo-fetal toxicity, always a concern as well. Watch out for hyperglycemia. This is something, again, can occur in patients that are first starting out with treatment. We actually have guidelines that patients with very high fasting blood sugars upfront should not actually be treated with EV. And then the patients who develop this hyperglycemia events, some patients with very high levels should not be rechallenged. There are some very rare cases of fatal events that are associated with hyperglycemia, a complex metabolic acidosis that includes lactic and diabetic ketoacidosis and acute kidney injury. And there have been some, very rare, but unfortunately fatal events that are associated with this that we're still trying to understand. Neuropathy that I talked about, this is as per the label. The first event of a grade 2 event, as per the label, tells us to say, hey, listen, withhold and then resume at the same dose. I'll tell you that in clinical practice, it's probably much smarter to withhold and resume at a dose reduction or do dose reductions early. This is pulled basically from the protocol, and so therefore it's recapitulated on the FDA label. But in clinical practice, neuropathy is slow to onset. And then because it's so slow to onset, it takes a while for it to get better. So re-challenging at the same dose is going to be highly problematic. And duloxetine is very useful, gabapentin, physical therapy. A lot of things can also help mitigate the toxicity, but really dose reduction is important consideration. Again, I've mentioned this again. So for ocular toxicity, artificial tears, ophthalmic topical steroids, I send all my patients to an ophthalmologist if they have, significant issues. And then skin toxicity, once again, I mentioned topical steroid creams and moisturizers and also antihistamines are quite effective treatment. Higher grade events also have been reported, such as Stevens-Johnson syndrome. Obviously, that's a very, very different kind of situation to be in. For those patients, they should be discontinued permanently. So it's obviously very important to educate our patients about adverse events, to know what to look out for and know when to report, those toxicities. I think it started off obviously with chemotherapy. We tell our patients, hey, listen, if you have a fever, you're not feeling well, call us immediately. Same thing with these novel agents, but it gets even trickier primarily because, each agent is going to have its unique set of toxicities that need to be managed, differently, right? So, skin toxicity from EV is managed a little bit similar to what we do with immunotherapy, but if a patient develops diarrhea to SG, for instance, that's managed quite differently than immunotherapy-related diarrhea, right? And there are future trials that are going to start combining these agents. I'll tell you, those trials are currently underway, which is going to make it even tougher to figure out and sort out, well, which agent is causing what problem. And so really important to really, assess communication, education, so the patients know how to sort things out. And really, they should, communicate all adverse events as they develop, especially so that we as clinicians can, triage these patients to appropriate management as they come along. Some AEs are inevitable. They essentially all should be able to be managed. And again, I can't stress enough the importance of reporting any unusual symptoms or adverse events. A majority of the time, early recognition and management is very, very critical to improving any associated outcomes. And also education, and this takeaway is really important here, educate patients and their caregivers in particular, because their support system is often heavily involved in addressing these symptoms and getting the patients to where they need to be in terms of getting the care that they need. All right, let's continue on with the case, Terran.
All right, our case concludes. Sean's rash has resolved with steroid treatment. His UC is responding to enfortumab vedotin. He has no other unusual symptoms, but he's aware of the need to call the office immediately if he does. It's a good case resolution there.
Great. So what other agents are currently under study in advanced UC? So I limited this just to a couple of ADCs, one ADC and other FGFR inhibitors and other checkpoint inhibitors, but there's a lot going on in the field. So RC48 is another antibody drug conjugate that other companies are currently co-developing, which is a HER2-directed ADC, but the payload is MMAE, and we'll see what that drug shows, and there are trials that are currently going to be launched. There are other pan-FGFR inhibitors that are listed here: derazantinib, infigratinib, pemigatinib, rogoratinib. These are in phase 1, 2, and potentially 3 setting. Infigratinib is in the adjuvant setting in the Proof 302 study, in particular for patients with high-risk upper tract tumors with FGFR mutations. And that's being supported by the SUO CTC. And then also recently reported out are selective FGFR inhibitors such as LOXO-435, which are selective only for the isoform-specific ones like FGFR3, which theoretically could have an improved safety profile as well. And I'll finish off with other checkpoint inhibitors. I kind of touched on this earlier in my talk, which is there still may be a role for CTLA-4 blockade with higher doses of ipilimumab. This is at 3 mg per kg. The phase 3 study of Checkmate 901 is currently ongoing and still recruiting patients. And so these are some of the agents that to look out for, but heck, there's so many more that you can't cover all of them because there's so much activity and development going on in bladder cancer that may improve and expand upon new standards of care in the next several years. And so look out for it. All right. So let me cover some takeaways. These are the key points. Number one, in patients in the first line setting, the first thing you got to do, determine if the patient is eligible for cisplatin-containing chemotherapy. It's the most important treatment we still have as of December 2021 is still the only one that's associated with the survival benefit in the first line setting and potentially cures. So that's the most important consideration. In the platinum refractory setting, maintenance or second line immunotherapy is either is reasonable, although maintenance has recently shown a level in evidence. So I think most are leaning toward maintenance now. Very important to identify and avoid concomitant therapies that might interact with cancer treatment. I think that's really, really kind of oncology care 101. And then, of course, educate patients and their caregivers about reporting unusual adverse events early, so that you can prevent higher grade toxicities from developing. I think that's the number one thing we learned, especially early in the immunotherapy era, is that early reporting prevented ER evaluations and hospital admissions. And we've learned a lot of valuable lessons from that experience.
So we're going to move on to our case study panel discussion, and we'll start with our first case. A 67-year-old gentleman presents with hematuria and undergoes a TURBT showing a T2 urothelial carcinoma of the bladder. He has a radical cystectomy, prostatectomy with lymphodissection with urinary diversion. Pathology is PT3A-N1 high-grade urothelial carcinoma into the perivesical tissue and one perivesical lymph node positive. He gets adjuvant cisplatin-based chemotherapy and gets through 3 cycles, but stops due to significant weakness and worsening of renal function. 10 months later, a surveillance CT shows new lung and liver mets. NGS of the liver mets demonstrates a FGFR3 TACC3 fusion. He receives pembrolizumab for 3 doses with rapid disease progression. How would you manage this patient, Dr. Balar?
Yeah, so I think, patients like this, who had a cystectomy, had high risk disease, we attempted to give a patient like this adjuvant chemotherapy. By the way, this is usually not how things go. You usually try to give neoadjuvant chemotherapy and then cystectomy, but things were switched around. And then immunotherapy wasn't effective. This is where you might reach for a drug like EV. There's a survival benefit shown in patients like this. So probably EV is what I would reach for. And especially because the patient has liver mets where we see particularly, robust activity for enfortumab. That's probably what I would use in this setting.
Thank you, Dr. McKay, for joining us. I'd like to hear your thoughts on this.
I agree. I think there's a lot of data for EV. It's interesting because we use these checkpoint inhibitors in the clinic in bladder cancer, but the primary PD rate to checkpoint inhibition, and Dr. Balar, you'll have to correct me if I'm wrong, but almost approaches 50% in some cases. And so we need better therapies. And it's not uncommon that we have patients who have primary PD to checkpoint inhibition. So I think EV is a highly effective agent. I think the FGFR3 fusion opens up the door for erdafitinib as well to be considered. Erdafitinib can be sometimes a tough drug from a quality of life standpoint, but I think EV or ERDA are likely the 2 things on the table here.
Great. There is a question that I think relates. I'm going to ask this to go along with this case. Do EV side effects include ATN or acute tubular necrosis?
To my knowledge, I don't think we've really seen nephrotoxicity manifest as ATN as in patients who are treated. In fact, there was actually a renal dysfunction study as done as part of the phase 1 program. So patients with very low GFRs of less than 15 cc's per minute actually is quite safe to give. And to my knowledge, we have seen very little to no renal toxicity. So I think it's relatively safe to say that if there are episodes of ATN, they're extremely few and far between.
And I agree with your point that we would have assumed this gentleman would have had neoadjuvant chemotherapy. So it leads me to ask a related question of the panel. If he was not cisplatin eligible preoperatively and underwent cystectomy, we could assume a couple of things here. I've seen patients receive reduced dose cisplatinum or split dose cisplatinum to try and give them cisplatinum, or would you just go to immunotherapy?
In the perioperative setting, or are you talking about?
Adjuvant. In the adjuvant.
Yeah, that's a tricky thing. And I think that's why, I think you're referencing data from Checkmate 274 and their recent approval of nivolumab. I think it's an important addition to our armamentarium. So for patients who get neoadjuvant chemotherapy and still have persistent high-risk disease, that's where immunotherapy has a role. It's a sandwich treatment, right? It's not designed to replace neoadjuvant. And I've, really counsel our urologists and frankly, the sponsor of the trial to say this is really a part of the messaging about the role of this agent is that it's really a supplement to existing standard of care to really benefit our patients so we improve upon our existing cure rates. But to your point, there are some patients who, let's say, have very bulky, locally advanced tumors, hydronephrosis. Despite your best efforts, you're not able to improve their kidney function with stents and so forth. After cystectomy, the miraculously improved kidney function, and now you're able to give adjuvant cisplatin. How often does that really happen? Not all that often. But if it does, you're probably going to still give cisplatin.
Dr. McKay, anything to add to that?
No, I think it really highlights the multidisciplinary care for patients who have localized bladder cancer. And it's only getting even more multidisciplinary as Pembro was now, approved even for use in the CIS refractory setting. So I think it was really a ongoing discussion between medical oncology, urology, and honestly also radiation oncology, because, we haven't obviously addressed bladder sparing approaches here. This is not the intent of this discussion, but it's really a multi-deep picture. And I agree with Dr. Balar that it's, what we don't want to do is say, oh, well, I'm just going to give somebody adjuvant Pembro and not give them the potentially life-saving chemotherapy because it's a easier treatment. Like I could see how that could happen in the local, setting kind of, because cisplatin chemotherapy can sometimes be, can have its challenges, but this patient was clearly high risk.
And I want to just go back to something you said, Dr. Balar. So if this patient hadn't been cis eligible for neoadjuvant, would you have given him immunotherapy as a neoadjuvant?
No. And I think, we need data to support its use. There are one really good study that is currently ongoing that is looking at both neoadjuvant and adjuvant is the Keynote 995 study, which is initially looked at pembro before and after surgery versus surgery alone, right? It was amended to include now cystectomy alone versus pembro before and after surgery, cystectomy, and also a third arm of EV pembro before and after surgery. And so it's a 3-arm study, and that will really tell us is the pathologic complete response rates that we might see in the bladder to neoadjuvant pembro, is that a surrogate for DFS? And I think we need to establish that first before we routinely give neoadjuvant immunotherapy before cystectomy. So we have to see the data for that first.
Thank you. Dr. McKay, anything to add to that?
No, I completely agree. I would not give neoadjuvant immunotherapy. Again, not everybody responds to immunotherapy. These are patients that could potentially be cured. And the last thing you want to do is delay their life-saving surgery, giving them a therapy that's not actually indicated, have that therapy not work, and now they're inoperable. So that would be the worst case scenario, so I think doing things on label, I think is key.
Thank you both. Let's spend a few minutes on our second case. This is a 61-year-old male with a history of type 2 diabetes for 15 years, well controlled with an A1C of 6.8, CAD with a history of stents, but current hypertension is well controlled on angiotensin receptor blockers, beta blocker, and aspirin, and has dyslipidemia controlled. The BMI is 32. He's a non-smoker, consumed regular alcoholic beverages, PSA is at normal limits. He has 6 months of hematuria. The most recent month shows gross hematuria. Then he had a syncopal event due to pain, presented to urgent care, went by ambulance to the hospital, had radiating flank and pelvic pain. Hospital workup showed a CT mass, not definitive. Subsequent cystoscopy reveals rough appearing lining of the bladder, large blood clot. The biopsy is negative, and so it's attributed to hematuria. The patient tolerates this for about 3 months, gets better, and then has hematuria and dysuria resolve completely. And then a follow-up cysto 6 months later shows widespread UC across the bladder and the left distal ureter with TCC. Any comments on this case?
It's a little unusual that the initial biopsy in the bladder didn't show anything unless it was a truly just a biopsy. And this is a flexible cystoscope and you got a lot of clot in there. And if you got hematuria and clot, you really can't see anything. And any urologist will tell you that you got a really full grade. You have to do a CBI and you have to be able to visualize what's going on in the bladder in this rigid cystoscope and a quality TUR to get a good sample. And so that might explain it. And obviously, cytology might help you as well. But there are, for reasons that we don't fully understand, patients who will have just a lot of subepithelial disease that we just don't diagnose on first, resection. And they come back with recurrent symptoms. And then it's only, their second, look that we eventually diagnose them.
Dr. McKay, anything to add to this?
No, I think it is somewhat of an atypical case, but I think it kind of due diligence in pursuing the diagnostic evaluation. I think sometimes these cases can be quite challenging. It's unclear sort of what was the state of the bladder at the time of the initial cystoscopy, and actually sometimes talking to the surgeon is really helpful to see what they saw. Was it a matter of, I didn't see anything, or no, things were so obscured that it was non-diagnostic as opposed to negative. And I think if you're dealing with a situation where things are non-diagnostic, you need to pursue additional testing to get to a diagnosis, as opposed to, no, I sampled, I looked, I saw, and it was negative.
Thank you. And the other question for the case says, would MR contrast be helpful? At our facility, we use a lot of CT-IVP. Do you all tend to like CT-IVP or MRI urogram?
So the advantage of a CTU versus an MRU. So urographic images should ideally be done in any contrast-enhanced cross-sectional imaging. So that first off the bat, whether it's a CTU or MRU, the urogram is really helpful to visualize the urinary tract. The advantage of the MR urogram over the CT urogram, A, is obviously the contrast. It's obviously more renally safe. And then the other is MRI gives you that visualization of the layers of the bladder, the smooth muscle, and you can probably see to some degree, I think, depending on your radiologist and their expertise, the visibility of the tumor, the lining, muscle invasion, extravesical disease, I think probably a bit better, and the enhancement of the tumor a bit better with MRI. And I found that just in my shop, that MRI can be more useful in that regard.
Dr. McKay?
Yeah, I mean, the thing about MRI is I think it may not necessarily be readily available at every single practice, across the country or at community practices. It's not only the technique, I think it's also sort of the radiologist expertise for bladder-specific MR protocols. I think those are sometimes you need kind of a skilled radiologist who's able to actually read the scan and read it in a way that would be interpretable. So, I would just have a word of caution around that, because I don't think the protocols are broadly available and accessible with high level of rigor across all institutions and all practices.
I would tend to agree with that. We have a lot of community patients from a long distance from our facility, and you have to decide each time if you think they'll be able to get the MRI, the quality that you need for diagnosis. I think that will wrap up our case, and we have a lot of questions, so I'd like to move on to our Q&A section for the panel. So regarding erdafitinib, would you give this drug to a patient who has a history of glaucoma?
Intraocular pressures and CSR are two different issues. So to my knowledge, I think it's probably safe to give, but just to be on the safe side, I probably would have that patient see an ophthalmologist at baseline and just to make sure that that's probably okay. But I don't think a history of glaucoma precludes the administration of erdafitinib.
Dr. McKay?
Yeah, no, I would completely agree. I mean, I think it just, prevention is key. And that initial opto exam is always really helpful just to get a good lay of the land for the patient's ocular, conditions, whatever they may be. Should a patient develop any symptoms or toxicity during treatment, you have a good baseline. So it just kind of further reinforces the need for a good baseline opto eval.
Great. Something that you talked about at the very beginning of the talk, Dr. Balar, what is the risk of bladder cancer from prostate cancer radiation?
Yeah. So, if we're talking about radiation-induced tumors in general, it's less than 1%, overall incidence, right? Because if it was anything higher than that, I think, most of our patients who are getting prostate cancer radiation would be running for the hills. So it's a tiny fraction. And the other thing is that it's the timing of onset. So radiation-induced tumors, it takes, upwards of 10, 15 years to develop. And so I think that's also an important consideration.
All right. Here's another question from the audience. I think we addressed this, but I'll put it through one more time. What's your opinion on adjuvant treatment, post-cystectomy, T2 disease, and if they were high-grade papillary T2 disease, what's your opinion on adjuvant treatment and what would you give?
So assuming that this is a patient did they receive neoadjuvant chemotherapy?
No,
okay. So upfront cystectomy, a T2A tumor, maybe even a T2B, the data really doesn't support any adjuvant treatment. And they wouldn't have qualified for Checkmate 274. And if you look at disease-free survival and overall survival from the original Stein series that was published in 2001, the USC series of, over 2,000 cystectomies, et cetera, the overall risk of recurrence is probably less than 30%. And so I don't think there's much value in adjuvant therapy in those patients. So unless they have T3 or greater disease, I don't counsel about adjuvant therapy.
Thank you. Dr. McKay, anything to add there?
No, I would definitely agree. I mean, that individual would not have even met eligibility into the adjuvant trial. So I think the risk of recurrence is very low. We know that in the adjuvant setting, we overtreat the bulk of the patients that get therapy. And so we really need to be cognizant. While we think checkpoint inhibitors are benign, there can be permanent irreversible toxicity with checkpoint inhibitors. And if you are giving it to somebody who was never destined to recur, I think, that is problematic.
Thank you. So here's a question for both of you. What clinical trial in the advanced UC setting do you think is the most promising?
Yeah, so I think we probably could take turns, choosing our favorite trial. But, for me, I think that EV302 study is probably the one that's going to impact the most broadly existing standard of care, which is EV Pembro versus the platinum gemcitabine first line in all comers.
Yeah, I completely agree. I mean, I think that combination is incredibly active. We haven't seen a frontline combination like that compared to CIS. I mean, quite honestly, CIS has remained king in bladder cancer or queen in bladder cancer management for a long, long time. And there has not been any regimen that has even come close to sort of challenging the front line. So I think this is certainly, if this trial is positive, it's going to change the way we treat this disease.
Here's a question from the audience. I'm going to ask the question, but I'm not sure I completely understand how she's posed it. What's your opinion on ctDNA in driving adjuvant treatment?
Yeah, so this is a hot topic where a lot of folks are kind of piecing together lines of evidence. And so the background is, for those who in the audience who may not fully understand the question, is that there was a really important study called IMvigor010 that looked at the role for adjuvant atezolizumab versus observation in high-risk patients after cystectomy. It was a negative trial. However, a subgroup analysis in patients who had positive ctDNA after surgery, which means circulating tumor DNA, which is evidence of occult micrometastatic disease, or what we call minimal residual disease. Those are the patients who are at high risk of systemic relapse. There actually was a benefit in treatment with adjuvant atezo. And even if, and furthermore, the patients who had positive detectable ctDNA, if they converted to negative upon treatment with atezo, then those patients, really benefited and showed that, look, you can follow these patients. Maybe these are the patients who should receive immunotherapy. The problem is that atezo was never approved, but nivolumab was. But nivolumab was all comers, never involved ctDNA. And now people are asking, well, should we use ctDNA for use with nivolumab? My position is that, those are two separate trials, two separate analyses. I would use nivolumab for patients who meet the trial indication for patients, with high-risk disease after neoadjuvant chemotherapy, or have, high-risk disease and are not candidates for adjuvant chemotherapy, as per the label. And I would not necessarily incorporate ctDNA just yet. We need more validation.
I completely agree. I think the other thing comes down to the assay that was utilized, whether it was an off-the-shelf assay or a bespoke assay. The assay that was utilized in IMvigor was utilizing the Nektar platform, where they basically have the patient's residual tumor from their cystectomy and utilize it to generate almost a personalized panel to detect cell-free DNA in circulation. Not all patients that were enrolled on the trial were able to actually undergo that kind of testing. I almost want to say that almost 50% or maybe 40% of patients were not able to actually undergo cell-free DNA analysis testing. So I think there's a drop off there. And while the cell-free DNA positive patients do poorly, it's not that the cell-free DNA negative patients are not recurring. They're still
right. They're still recurring.
Yeah, they're still recurring, not as bad as the cell-free DNA positive patients. So I think that there's still a lot for us to learn about application, and we really need to design prospective studies that embed arm allocation based on presence or absence of cell-free DNA. So I think we still have a lot to learn.
Yeah, and that trial is called IMvigor011, and that trial is happening. And so that will sort out how ctDNA really fits in.
Here's another question. In your experience, what do you do in your practice to help patients understand and recognize the toxicities associated with therapies, especially those that need to be heard about for early intervention?
I try to take as broad an approach as possible, and primarily because we may start with one treatment today, but in 3 or 4 months, we may be starting another therapy. And so I counsel less about the specific toxicities because it can be so overwhelming for the patient in that moment in time. What I counsel them more about is just general value of communication, the key team members, who they should call and how to reach them. And just the general counseling of, if anything's bothering you, if any questions you have, something just doesn't feel right, call us immediately and we'll help you sort it out. And I think that as a general approach has been, I think in my practice, been very effective. Now, there are times when patients are just starting out a brand new therapy where in the first 1 to 2 weeks, there are really key things that I need to look out for. And so I'll counsel them specifically about that. But I think a more general approach has just been, listen, anything doesn't feel right, these are the key people that you call.
No, I completely agree. I mean, it's all about another multidisciplinary team thing here. But I think what's critically important too is education of staff, because, patients call the clinic with various symptoms, and somebody that's calling with a little bit of diarrhea, it could be a big deal. Say if they're on immunotherapy and they're having, 4 loose watery bowel movements per day, if the person that's kind of triaging that call doesn't know or doesn't look in. So I think there's a lot of education that actually happens to the entire, nursing team, MA team, our, APPs around, tox management. So I think that's critically, important. And to realize when there's a red flag and something needs, an immediate attention and a flag to it versus not. So I think it's patient education. I agree that the education to the patient is always to err on the side of caution and call. Don't wait till the visit. Like if you're having something, you're not really sure what's going on, just call us. We'll triage it for you. And then the education is also to the staff on what is that actual triage model. I know that some programs now with the introduction of IO, they have like almost like a break the seal. Like if somebody were to, present to the ED or something, there's like a flag that's like, I've received an immunotherapy within the last 30 days or something like that. So it's also beyond just the practice, but also the primary care doctor, the ED physician. So I think it's crucial that, these things are evident within the medical chart. It's clearly, documented. There's appropriate training for staff.
It's always disheartening to have a patient's spouse or family member say, well, when we were in the hospital elsewhere, and you're like, wait, what? You were in the hospital? So
yeah. Like, why didn't you let me know? Exactly.
All right. I'm going to squeeze in one last question really quick. Dr. Balar mentions starting phosphate binders if phosphate is less than 7. There's a DDI interaction with erdafitinib and phosphate binders. What should we be watching out for?
There aren't, so thankfully. So there are some key drugs that we can use, like Foslo. I think that's what we use most often. So actually that hasn't been an issue. And it's actually phosphates that are above 7 that we use it for.
Thanks for clarifying that. Anything to add, Dr. McKay?
No, I think that's great.
Thank you. All right. Well, we're going to wrap it up. It's been an amazing talk. We've had great interaction. We really enjoyed the panel discussion and all the questions from the audience.
Thank you for listening to the Practicing Clinicians Exchange podcast. To claim your credit, please visit pce.is/GIGU. And while you're there, don't forget to check out our website for more complimentary oncology CE/CME activities.